Professor of Anesthesiology. Today I am talking and discussing with you basics of liver, anesthetic management, a little bit of cirrhosis, and what are the various liver diseases and what you should know about the basics when you are dealing with liver as an anesthesiologist. I'm sure you know the liver gets blood from two distinct sources. One is hepatic artery, the other is portal vein. Oxygen-rich blood flows through the hepatic artery, while the nutrients from the intestines come from the portal vein. I'm sure you know it, but you might have forgotten. What exactly is the difference between hepatic portal vein and hepatic vein? This question can be asked during the viva. The hepatic portal vein carries nutrient-rich blood from the intestines and other parts such as the gallbladder, pancreas, spleen to the liver, whereas hepatic vein carries deoxygenated blood from the liver to the vena cava. I think it's inferior vena cava. Okay, that's it. So, when you're talking about cirrhosis, you must know the presence of cirrhosis is always associated with significantly increased risk of post-operative morbidity and mortality. Yes or no? It's very much there. And how do you do the scoring? Child, Pug, Turcotte. Child, Pug has brought into the scoring way back in 1964 if I'm not wrong. And Turcotte, Turcott, has modified that scoring way back in 1973. So whatever it is, CPT or Child Pug Turcotte scale, okay, CPT, and the model for end stage liver disease. This is, many people say it, modified, end stage liver disease scoring. No, it's not modified, it is model for end stage liver disease, MELD. This scoring remains the most commonly applied scoring system when you are talking about preoperative risk assessment of cirrhosis of liver. But, when you talk about these two, CPT, that is Child Pug Turcotte scale, and MELD, that is model for end stage liver disease, any day MELD is better. Why? I'll tell you. Well, MELD has better prognostic value compared to this. What is it? Turcotte, Child Pug Turcotte. I'll prove it beyond doubt. And what happens exactly when you're dealing with these two? CTP scoring system, okay, has an inherent problem. Child Turcotte Pug system has inherent problem when you are evaluating. Like in CTP, we take into consideration HE. HE is hepatic encephalopathy and also ascites. Now, two people are evaluating these two. One person can say it is moderate ascites, the other person can say it is same ascites as severe. And two person evaluating HE, that is hepatic encephalopathy. The same person, one person can say it is mild, the other person can say it is moderately severe encephalopathy. So, you cannot evaluate and score correctly. So, something other than that. And moreover, in CTP there is the biggest problem, the higher limit, like when you are evaluating bilirubin level, anything more than 3, you give scoring of 3. Suppose the person has 3.5 milligram or 4 milligram per deciliter and the other person has got 20 milligram per deciliter. Both will have same score, that is 3. So obviously it can't be relied upon. So obviously Child Turcotte Pug score, though widely used in clinical practice, has not been validated. Okay, and another thing, in MELD, 3 things are taken into consideration, like serum creatinine, that is most important, which is not taken into consideration in Child Turcotte Pug. Serum creatinine is more valuable. compared to other things. Okay. Albumin, bilirubin, and INR are common factors in both MELD as well as CTP. But in MELD, mode 4, and say liver disease scoring, we take into consideration serum creatinine. Okay, now any value less than 1 is always 1. But if dialysis has occurred twice in the previous 1 week of surgery, the creatinine value goes up to 4. So that is very important when you are thinking about that. And another thing, when you are saying the score between CTP and MELD, other thing, suppose in MELD the score is less than 10 or 10 to 14 or more than 14. So these three are equivalent to CTP ABC. Less than 10 is equivalent to CTP A. 10 to 14 MELD scoring is equivalent to B. And if it is in MELD scoring is more than 14, it is equivalent to CTP score of 3. Then there are certain things which you must always know, like what the drugs you are giving, like sodium pentothal you are giving. See, the affinity of albumin to the sodium pentothal is very high. And obviously, in hepatitis and cirrhosis are the problem, the albumin level goes down. Hence, the dose of these drugs is reduced because whatever you have given, the volume of distribution has come down because of low availability of albumin. So, you have to give lesser dose of sodium pentothal, thiopentone. Okay, propofol is the anesthetic drug of choice in patients with liver disease. It has short half-life. Even if the patient has decompensated cirrhosis, propofol has short half-life. That's the beauty of propofol. So go for it. And if the patient has gamma globulin excess, obviously the volume of distribution can significantly be decreased. In that case, dose of the drug has to be accordingly seen. In that case, you have to increase the first effective dose of the drug, obviously, isn't it? And one more thing I wanted to tell, like if they have coagulopathy is very common with all this liver disease. The first thing you have to give is fresh frozen plasma or cryoprecipitate, okay, and you can give platelets also. But what are the drugs which can treat hepatic associated coagulopathy? Never forget aminocaproic acid, tranexamic acid you can give. These are the drugs which can effectively treat hepatic associated coagulopathy, and recombinant factor 7 and one more, conjugated estrogen. These are the drugs which can be safely given in hepatic associated coagulopathy. Thanks for patient listening. Have a wonderful day. Take care. Bye-bye.